Welcome to Decoding DX. We're a group of fourth-year medical students with a passion for education and patient care.
This episode of Decoding DX is for educational purposes only and should not be used as medical advice. Please consult your healthcare provider for any medical needs.
The opinions expressed represents those of the participants and are not of our affiliated institutions.
Thank you for joining us on Decoding DX. We keep learning so much through this experience, and we're so glad that you're learning alongside with us. Now, let's get to the episode. Hello and welcome to another episode of Decoding DX. I'm Brianna, and today I have a special bonus episode for you on SIADH. As I was editing and preparing the Hyponatremia 10 clinical minutes for posting, I realized that I was quite unsatisfied with my own presentation on the treatment of SIADH, so I decided to make it its own video. To start off, same as the Hyponatremia video, this presentation was largely guided by the amazing book, The Fluid Electrolyte and Acid-Base Companion by Dr. Sarah Fabel and Dr. Jill Toft. The link to download this for free is in the show notes. It's an amazing resource that I highly recommend for anyone in medicine. And before we go any further, please watch the 10 clinical minutes video on hyponatremia if you have not already. That video serves as the foundation for a lot of what we talk about here, and it's really important to watch them in the right order. So to start off with, a little algorithm that I put together on the approach to hyponatremia. This was not in the hyponatremia video, so I came up with this afterwards, and I thought it was helpful to put into this video. So what we're going to focus on in this video is the true hyponatremia pathway with euvolemic status, which ultimately leads down to SIADH when you rule out other causes. Quick review of some slides from the hyponatremia video. ADH at the nephron. So you have the countercurrent mechanism of the tubules in the nephron that create this high concentration in the medullary interstitium, such that when the body triggers the release of ADH, it's able to unlock the collecting tubule and allow water to reabsorb into the kidney interstitium to then reabsorb into the body. With maximal ADH effect, we can concentrate the urine down to 1,200 to 1,400 millimoles per liter, and without any ADH effect, the urine concentration is about 30 to 50 millimoles per liter. And again, over on the side of the screen, we have the table approximately correlating urine-specific gravity to urine osmolality. So this gives us the two extremes, no effective ADH or maximum effective ADH. From this, we can concentrate the daily urine volume that is generated by a person based on their daily solute load that the body has to excrete and their urine concentration. If we have no effective ADH, that'll create 12 to 20 liters for a 60 kilogram person. And then for maximum ADH, that'll create about 0.5 liters for a 60 kilogram person. And again, this all comes into the balance of what's in versus what's out. So if you take in not enough of the amount of fluid that you're excreting in your kidneys, you'll get hypernatremic. On the other hand, if you take in too much, you'll get hyponatremic. And normally the body is able to balance what we take in with what it excretes out. That's the whole point of the ADH pathway and other hormone pathways, is to create the right balance. But when there's pathologies going on that manipulate those hormone levels outside of what the body is telling to it to balance, that's when we get problems. So SIADH, or the Syndrome of Inappropriate ADH. What that means is that there's ADH in the presence of either euvolemia or hypoosmolality. What we learned in the hyponatremia video is that the purpose of ADH is to either restore proper osmolality in the blood, or it can also be triggered in states of hypovolemia as kind of a catchback mechanism to help increase the volume status of the body. So if neither of those situations are present and there's still ADH being released, that's inappropriate and that should not be happening. And thus that's outside of the normal regulatory pathways of the hormones in the body, which is inappropriate. So the four main characteristics of SIADH in a clinical situation: you're going to have hypotonic hyponatremia, so low sodium in the presence of low osmolality. You're also going to have an overall euvolemic state, and caveat there, this is assuming ADH as the primary pathology of what's going on. Sometimes you can have SIADH in the presence of other factors that would, for example, dehydrate your patient, and they'd be hypovolemic. So this is a simplified presentation, but we're just talking about ADH here. Other two things that are really critical to establishing this diagnosis as different from other things is that the urine sodium will be greater than 20 milliequivalents per liter, and the urine osmolality will be more than 200 millimoles per liter above the plasma osmolality. Basically what this is saying is this is objective evidence that your kidneys are wasting sodium in a setting where they shouldn't. You have low sodium in your plasma. So your kidneys should be trying to absorb all of the sodium that they can from the urine to try and fix that. But in this setting, they're not. You're seeing this extra sodium and extra solute concentration in the urine. So the kidneys are not properly concentrating the urine as they should to try and correct the plasma concentration of sodium. Various causes of SIADH exist. There are all sorts of causes of these. In the hyponatremia video, I went through these a little bit more. The main point I want to make here is that the step one of treating SIADH is trying to figure out the underlying cause. Oftentimes that takes longer, and so we have to go ahead and start treating the hyponatremia in the meantime. But during the rest of the treatment, you need to be trying to figure out what's going on to cause this and trying to address that if you can. So how do we actually fix the sodium? One of the common thoughts is that if we have hyponatremia, we should be able to give them some normal saline, some 0.9% NaCl, and that should fix it, right? Because we learned in the IV fluid crystalloids video that sodium chloride has quite a bit of sodium in it, and it's higher than the normal plasma concentration, so that should fix the balance, right? Wrong. In reality, when you have SIADH, what's going on is that you're retaining water and you're excreting extra sodium, like we talked about. So if you add isotonic saline to that equation, you're going to retain the water from the saline, but you're going to excrete all the sodium. So in reality, you're making the hyponatremia worse by giving your patient normal saline. Because again, they're going to hold on to the water that's in that saline, and they're going to get rid of the sodium. So in effect, once it's gone through their kidneys with the SIADH pathology, you're just giving them water, which is going to make the hyponatremia worse. So what do we do instead? Well, if we have too much water in relation to our sodium, we need to get rid of the water. How do we know how much to get rid of? In a lot of SIADH situations, the hyponatremia is chronic, and so you don't have to fix it acutely. And in reality, you can just restrict the amount of fluid that your patient is intaking to correct this balance over time. So to figure out how much fluid restriction we need to put our patients on, there's a couple of equations that we're going to walk through. To start off, you need to calculate the water excess. To calculate that, I have the equation here. So you need to know your patient's weight in kilos, which is pretty easy to get. The percent of total body water. Now this is an estimation that we make based on known characteristics of the human body. So again, this is an estimation, but it's pretty good for our purposes. So in general, males, their percent total body water is 60% or 0.6. And then in females, it's 50% or 0.5. And then infants, it's a little bit higher at 0.7. And then you're going to take 1 minus their measured sodium that you get on your BMP over the goal sodium. So this can change based on what your goals for this patient are. We know that the normal range of sodium is 135 to 145. So maybe your goal is 135. Or maybe you say, we just want to get it to a safe range, which would be like 125 or in the upper 20s. So that's, you're able to choose that goal sodium based on your clinical judgment of what is the goal for your patient. The next equation is the daily urine volume. We've done this many times before in these two presentations. This is the daily solute load divided by the urine concentration. So this is going to be about 10 millimoles per kilogram. So you'll multiply that by the kilos of your patient over the urine osmolality, and you can directly measure this from the urine sample. You can order this as a lab, or you can also, if you have a UA, you can approximately get the urine osmolality from the specific gravity, and you can go back to that table that I showed earlier on that has those approximations. And then the last equation is the daily water maximum. So this is the maximum amount of water that your patient can take in given the other equations that we have figured out. So this is going to be their daily urine volume that we already calculated minus their water excess that we already calculated over the number of days that you want to correct the sodium. And this is an arbitrary number. This is really just a matter of how acutely you want to fix the sodium level. As long as the rate is less than 12 milliequivalents per day on their BMP, you can choose any number that you want. So if this is something that you want to correct before they leave the hospital, you can put in maybe 5 or 7 days, however long you think they may be in the hospital. If this is an outpatient, you can choose maybe 14 days, 20 days, whatever is appropriate for the clinical situation. Okay, so let's run through an example. So let's say we have a 70-kilo male with a serum sodium of 125 and a measured urine osmolality of 500 millimoles per liter. So with our first equation, we're going to plug in his weight, his total body water as 60%, as he's a male, 0.6, and then his measured sodium of 125. And let's set his goal at about 135. That's the bottom limit of the normal range. And with a 125, that's not too far off of that, so I think we can shoot for the normal range. So when we plug these numbers in, we'll get a 3.1 liter water excess. Next up is the daily urine volume equation. So in this situation, we have the daily solute load of 10 millimoles per kg times a 70 kilo male. And then our urine concentration is what we measured on his actual urine, which was 500 millimoles per liter. That'll give us a daily urine volume of 1.4 liters with the amount of ADH that his body is excreting and using. Last equation is the daily water maximum. So his daily urine volume of 1.4 liters minus his water excess of 3.1 over, let's take 14 days to correct. Let's say this is an outpatient and we're not terribly concerned, but we do want to get this corrected in a decent amount of time. So we'll have him come back in 14 days. That'll give us a daily water maximum of 1.2 liters that we can shoot for. So what this means is that for our patient, what we're going to do to treat is we're going to put him on a 1 liter fluid restriction for 14 days. And we'll have him come back in 14 days. We'll recheck a BMP. We'll see where his sodium is at. Then if that corrects his sodium, thereafter we will tell him to have no more than 1.2 liters per day, because that's the amount of water that his body is producing in his urine by the amount of ADH that his body is working with. So we know that, the patient isn't going to be able to say exact 1 liter every single day. So that's why we went a little bit under the daily water max at 1 liter to give us a little bit of wiggle room. And then we're able to remeasure, readjust, reassess, and go from there. Lastly, if the cause can't be fixed, let's say this is a patient with a paraneoplastic SIADH and we're not able to fix that situation. We come back to the equation of daily urine volume being the daily solute load over the urine concentration. So let's say their daily urine, their max is like 1 liter, and that's just too restrictive for this patient. They just can't have a good quality of life with that. What's a way that we can increase that? Well, we can increase their daily solute load, or we can decrease their urinary concentration. Ways to do that. Ways to increase their solute load, you can give sodium tablets, and you can also give urea tablets that help increase the daily solute load. You can also decrease the urine concentration using a medication called demiclocycline, but this is only used by specialists in specific situations, and that also goes for the sodium and urea tablets as well. So just know that these options exist, but this is not going to be the type of thing that a generalist is typically prescribing. This is something that they're probably going to need to see a nephrologist for. So some key points. Treatment of SIADH. Number 1, figure out what's going on, address that underlying cause. Number 2, fix the water to fix the sodium. The way that we do this, we have to do some math. So we're going to calculate their water excess. We're going to calculate from that their daily urine volume, and then their daily water maximum. From that, that'll give us the amount of fluid restriction that is reasonable to put them on, that's below their water maximum, so that they can then correct that hyponatremia and prevent it from coming back. And finally, if you have any comments, questions, concerns, please feel free to comment below or send us an email. We'd love to hear from you. Thank you so much for joining us on this episode of 10 Clinical Minutes. We'll see you next time.